Hello, welcome to Life Matters. I'm your host, Brendan O'Connell. Well, the pro-abortion lobby, both here in America and worldwide, claim that legalized abortion reduces the risk of maternal mortality. Is this assertion true or false? And which action results in a greater risk of death for the mother, giving birth to a child or having an abortion? Today's Life Matters show examines the issue of maternal mortality. Our guest has studied the medical literature in depth. He is a medical doctor, an obstetrician and gynecologist, and he's looked at a lot of these issues. And today we want to dig in and find out what's really going on and what is the truth. Is giving birth better for the woman or worse? Well, welcome to our guest, Dr. Byron Calhoun.
Hello, thank you.
Hi, Dr. Calhoun. Well, Dr. Calhoun, you recently gave a presentation at the American Association of Pro-Life Obstetricians and Gynecologists, and you entitled it, "The Myth That Abortion is Safer Than Childbirth Through the Looking Glass." What did you try to achieve? What are you trying to get across, and what are some of the issues involved with the whole idea of maternal mortality?
Well, the problem is that it has become almost like an urban legend or a mythical story that's taken on a life of its own. And so I use the idea that basically Alice in Wonderland is where you enter into this whole discussion, because none of the rules apply and you're going down into the rabbit hole to talk about statistics and numbers which are simply not supported by the data, particularly in the United States. And when you look carefully at really good linked data in other countries, it just doesn't hold water. That childbirth is more risky than abortion. In fact, it comes out the other way. That actually induced abortions, particularly surgical abortions, are far more risky to women than are childbirth in comparison. When you actually look at the data.
Can you separate between surgical abortion and medical abortion?
Well, you really can't do that very well. There is some literature out there on medical abortion and talking about safety, but a lot of it has not been well done yet, and a lot of it, once you look at the complications from medical abortions, of which up to 15 to 20% end up in surgical abortions, you end up, again, with much higher mortality rates and complication rates than you would with childbirth. So there's a lot of, again, mythical information placed out there as truth, but when you look at the actual mortality rates, it doesn't really hold up under scrutiny.
Well, wasn't there a study done saying the risk of death is with abortion?
Yes, there's actually been a couple of really good linked studies in Finland where they actually did looking at all the health causes and all the maternal mortalities regarding abortion and compared it to actually childbirth and or stillbirth. And what they found was that in the linked data that after a year after an abortion, women who aborted had 4 times the risk of death than those who carried to term. They also found that the mortality rate was about 1/3 to 1/2 of the risk of dying after a childbirth than after induced abortion. And in fact, it was about 3 times higher in a subsequent study that they did later on in 2004. And the reason that's important is that if you don't look at the all-cause mortality rates in terms of suicide and late-onset death, and you don't link them, then you don't know that those are related to abortion. So it's very important that the data be linked together and done appropriately. And it just isn't available in this country. In fact, if you look at the CDC and other people, they'll tell you that their data is unreliable. So we don't require mandatory reporting, we don't have review, and there's a limited number of states report abortion complications, and most of them it's voluntary even in those states. So there's no direct linking of records and very poor data, in fact, on all that information in the United States in particular.
Well, I thought that this Raymond and Grimes study said that the risk of death associated with childbirth is approximately 14 times higher than abortion. How could they come out with a study like that when you are just telling us about the studies in Finland that are really directly opposite that?
Well, it becomes that's why I talk about through the looking glass. It becomes a manipulation of the language. It becomes a manipulation of how you define mortality rates. It becomes a manipulation of how you compare death rates among various classes of people. For instance, if you look at maternal or deaths due to pregnancy as compared to live births, if you look at abortions as compared to perhaps the number of women who become pregnant, which is an entirely different group of women. So you don't have the same denominator, and so you get a different result. Or if you don't count all the deaths from abortion because they're not attributed, that also decreases the number. So you really can't get to that number, and you actually can't compare a 9-week or 6-week abortion to a full-term pregnancy at 37 weeks. That's not a valid comparison. You have to go week by week through the pregnancy. And when you do that, actually abortions come out, particularly after 16 to 20 weeks, to be far riskier for women to have than are going to term of having a baby.
Well, can I ask you, why is trimester analysis important or not important when they go ahead and talk about births and mortality?
Well, because obviously if you do a first trimester, say, before 12 weeks, 6-week abortion, that's found to be relatively, quote-unquote, easy to do because it's a relatively small pregnancy. It's a pregnancy that's not well-developed. But if you look at a pregnancy then and compare that to a woman who has preeclampsia at 35 or 36 weeks, that's a completely different discussion because that woman is now 35 or 36 weeks. That's not an early 6-week pregnancy. It now has a medical complication that's associated with the pregnancy that is not present at 6 weeks. So they're comparing apples and oranges. And if you look at, in fact, by trimester, for instance, there was data been done back in the late, probably 2004 and 5, looking at mortality rates, and it said if you do surgical abortions in particular, the mortality rate increases from about 14 per 100,000 procedures at, say, 13 weeks to almost 30 at 16 to 20 weeks and almost 80 by 21 weeks. Well, those are way higher than the quoted mortality rates of 8 to 10 per 100,000 at term for pregnancies. But they never talk about that. And that's the disingenuous nature of this whole discussion, is you just change the statistics so to suit your argument in the narrative and don't honestly deal with the data and actually pull forth good data and compare apples to apples and oranges to oranges.
Well, I know that oftentimes we have to rely on the Guttmacher Institute, but aren't they have a profit motive, or aren't they politically motivated in what they report?
Oh, absolutely, and they are an abortion advocate organization. And even on their website, if you read carefully, they will also say that their data is not to be used for interpretation or use in statistical analysis, because again, remember, their data is from voluntary reporting from abortion clinics who are not obligated in any way, shape, or form to share any of their complications or report their data accurately. And there's no way to double-check any of the data that they have because it's all voluntary, and it's, of course, not open to public purvey for the most part because it's voluntarily reported anonymously from the clinics. And again, and they themselves even say not to use it for scientific purposes or the purposes of doing research, even on their website. And so, again, the two most common groups that are talked about to have, quote-unquote, the best statistics on abortion, both say they're unreliable and shouldn't be used. But yet, Dr. Grimes and his friend are using those very statistics to try to make a point that's not true. It's not a proper comparison. And they know better. They absolutely know better, and they should know better. And it's really unfair to report this sort of data out without a disclaimer.
But the abortion industry uses that study, is that correct?
Oh, absolutely. It was printed in the American College of Obstetricians and Gynecologists, my own college's journal. And if you challenge any of that, then of course you're considered to be, unscientific. You junk science, the usual smears of ad hominem, fallacies.
So there's political.
There's a narrative.
Yeah.
There's a narrative. Yeah. And again, if they would just honestly say, look, the data are unreliable. The best we got is this. And we could then discuss it in a rather scientific manner, than to throw it out on the table as if that's the way it really is, and to ignore all these other studies, of which there are numerous. I mean, again, that just came out with a study that I worked on with a group of co-authors out of Mexico, which has actually very good data, and it looked at the abortion, either restrictive, quote-unquote, no abortion, or liberal, meaning elective abortion, particularly in the city around Mexico City, the Republic's capital state. And we found that in our looking at about 10 years worth of data under hundreds of thousands of women actually, that the liberalization of abortion did not decrease maternal mortality. In fact, it was higher in the states with liberal abortion laws than it was in states with restrictive abortion laws. Therefore, to say that abortion liberalization decreases mortality is again, it's specious. It's not true. In the natural, the real world experiment that you see and when you do the data.
Can I ask you, one of the things that I've noticed and have talked to a lot of sidewalk counselors and things of that nature, and they say that if there's an injury in an abortion procedure at an abortion clinic, they're often rushed off to the emergency room. Is that, I mean, and if they die over there, for instance, we had a woman at the Cape Cod Hospital back 4 or 5 years ago where this situation happened. She was probably asphyxiated from the drugs that they put in her.
Correct. Yeah, over-medicated. Yes.
And what is there any way to is there any way to get those statistics and bring them back to show that it was really the abortion at the abortion clinic where they operated on her and in effect killed her?
It's virtually impossible without mandatory reporting and actually making people that are doing abortions actually have credentialed privileges at hospitals and be forced to deal with their own complications and attribute the complications appropriately to the abortion. In other words, once they just come into my system, perhaps at my hospital or other hospitals, depending on how it's coded out, it will never even be known that that was an abortion complication. It'll just be noted as a hemorrhage due to DNC, and they may never talk about elective or induced abortion. It's very difficult to get that data. That's why my plea has always been, like everybody else, is to say, why don't we sit down and find out how to do the best job of getting reporting of our surgical procedures, particularly abortions and other things, and make a real database and get real data, like all the other countries of the world have done.
I see it. And during your presentation down in Washington, D.C., you talked about just trying to get people to define mortality is an issue. Could you explain a little bit briefly about that?
Well, the problem we have is that there's different definitions in different countries. There's different definitions depending on which database you're using. It depends on how long you attribute the complication or the abortion or the surgical procedure, for that matter, but childbirth, to the cause of death. And there's actually about 8 or 10 different ways of doing this. Furthermore, we also know that because the abortion and the birth are not reported, even sometimes, particularly in certain states, don't even have maternal mortality boards where they actually review maternal mortality. There is virtually, it's a free-for-all. I mean, there's multiple different definitions, and people use different definitions to try to define mortality rates, either like, say, 7 days after a birth or 7 days after a procedure, some out to a year, and then they use different numbers. So like I said earlier, you could say, well, what about if you did it per 100 abortion procedures, which would be the appropriate way, versus comparing abortion deaths per 100,000 live births. Well, live births have nothing to do with abortion. That's a pregnancy. That's a totally absurd comparison, frankly. If you wanted to compare abortion, you'd have to compare by procedure, and you'd have to compare it by week of pregnancy, not comparing pregnancies that are going to go to term, which is live birth, to a procedure that never intends to go to a live birth. So it becomes, as you see, it's like you said, you're going into Alice in Wonderland. There's all this very interesting stuff, and it's like, you know, every word means exactly what I mean it to mean, no more, no less. You kind of feel like you're out there somewhere with the Red Queen.
Mm-hmm. And I just was going to ask you, is there a statistic for direct obstetric deaths?
Well, there actually is, and that one is usually the idea that the death occurs as a direct result of the pregnancy, and most commonly that would be something like a postpartum hemorrhage, someone who had bleeding from their delivery. There might be another one that perhaps a rare occurrence, say, regarding someone who had an amniotic fluid embolus and died as a result of the delivery, or died as a result of cesarean section with hemorrhage in the cesarean section. Those would be direct deaths related to the pregnancy, as a result of being pregnant. And those are sort of or anesthetic death theoretically could be linked to the pregnancy and delivery, but that would be more associated probably. But the direct ones are what happens when you deliver or when you have a pregnancy that goes, to term.
Mm-hmm. And I was looking here at the the case fatality rate, induced abortions. Can you talk a little bit about that? Maybe you have already, but for instance, a lot of these people also, they have, I've had many a guest who have psychological issues, drinking issues, subsequent to having an abortion. How long out, what kind of a time window would you give for someone who's been damaged by the abortion, but it doesn't immediately reflect?
Right. Well, that's the problem you have is talking about case fatality ratio is using the idea that we would know how many legal induced abortion related deaths per 100,000, say, reported abortions. That would assume that we know all the deaths identified from all causes up to 1 year. In our country, we have no idea how many abortions are done because it's voluntary, and several large states don't report at all. And we also don't know what deaths are attributed to abortion because, again, in our country, they're not necessarily recorded as, like you pointed out, with someone who comes from an abortion clinic and dies as a result of a hemorrhage or something in the hospital is not counted as an abortion death, which is why it's so important to have linked data like the Finns have and like the Mexican database had to be able to look at all those procedures and everything that happens within, say, if you're going to do a year after a surgical procedure or abortion or after a birth, and be able to control for all the different other factors that are related to that.
Mm-hmm. And it is my understanding that if you have an abortion, your risk of suicide goes up significantly. Is that true?
Absolutely. I mean, the risk for suicide goes up. Well, there's actually several different things that looked at that, and probably depending on several times. I mean, there's been a couple of studies actually that were linked, and actually Dr. Gisler did another study looking at suicide rates, and the rates went up. I'm trying to think exactly the number. I don't want to misquote it, but I'm trying to think about it's about. Let's see. If you had, they did a study, Dr. Gisler study, 2005, and they found that the abortion caused the suicide rates to be double at least. And in the United Kingdom, they did some studies as well and found that they were about 6 to 7 times higher suicide attempts per 1,000 among those who had abortions compared to those who gave live birth. And the rates of substance abuse are several 100% higher, and alcohol abuse and just other substance abuse-related problems as well as depression, anxiety, sleep disorders are all elevated in people post-abortion.
Mm-hmm. And I know you talked a little bit about it, but on the mortality measurement issues, why are they underreporting to a huge degree? Is that purposeful?
Well, the short answer is yes, and the other simple answer is that there's no requirement to do so, and there's no incentive to do so. The best way to make it work is to tie the incentive to some sort of remuneration or lack of remuneration. In other words, you need to report what you do, or you don't get paid, or you somehow have to pay for not reporting. Or you set up, as we talked about in the Affordable Care Act, we're going to set up this database, which of course is not part of it, which ought to be. So we can look not just at like abortion and mortality rate, but we can look at other important health issues in our country as well that are related to health, surgical procedures, other things we know that are associated with poor health outcomes, sanitation, and other things that we could look at. I mean, there's just lots of things that we done with that. But the big thing is they don't report. And if they do report, they are voluntary and or they're not reported properly or attributed to the abortion procedures because there's no data.
Mm-hmm. And you mentioned in your presentation about uncomplicated abortion focus on uncomplicated abortion, where statistics for childbirth incorporate complicated delivery, C-sections.
Right.
What was that to? Why were you comparing complicated and uncomplicated?
Right. Well, I mean, it makes, if you think about the surgical procedures that are done for most early surgical abortions, it's a D&C, or dilatation and evacuation, which is a relatively straightforward, uncomplicated procedure. In a healthy young woman, that's relatively, quote-unquote, benign as the surgical procedure at 6 or 7 weeks. Of course, the problem with that is then you're comparing that patient to the patient who now is, 35 years old, has chronic hypertension and diabetes, and has preeclampsia at 37 weeks, and you have to do a surgical procedure to deliver her baby. So you're trying to compare that patient to a patient who's completely different. So you can't compare apples to oranges. You have to be able to control for the demographic and the medical complications to be able to make valid comparisons between patient groups. That's not fair. You can't say you're going to take a totally uncomplicated group and compare it to another complicated group and then draw a conclusion from it without controlling all the factors, which they don't do.
Mm-hmm.
No one said if you take a chronic hypertensive, diabetic, obese, overweight, ill patient who needs a surgical procedure like an abortion and compare her to the lady who's now 37 weeks with preeclampsia or needs to be delivered. That's not being done.
Mm-hmm. And what about the... I know that the pro-abortion side, for instance, doesn't like to hear about the abortion-breast cancer link.
Right.
It takes roughly 8 to 12 years usually to manifest itself, but that means a lot of young women in their 30s and 40s or early 50s are coming down with breast cancer.
Right.
Are these mortality items, are they being included in the risk of abortion or no?
No, they're not, and that's, again, part of this whole idea. It's much like the cigarette story, the tobacco story. I tell everybody said in the 1940s and 50s that tobacco was not associated with lung cancer and increased mortality and all this other stuff until they finally looked at it and did the work and said, wait a minute, it definitely is associated. But that took, 30, 40, 50 years. I mean, people started smoking cigarettes in World War I, really, when they, had cigarettes initially and they gave them away so they could sell them. And it took 40, 50 years, and then, of course, 15, 20 years after the exposures in the shipyard. So it took that long for that data, epidemiologic data, that life data to come out. So when you have breast cancer, it's the same idea. It takes time for these tumors to grow and the effects and exposures to take effect. So that's the same story. It takes time. And now there's in fact, there's just another study out of China, and there's been several out of India, looking at the just huge upsurge of breast cancer in those countries in the last 10 years or so, and it's now riding on the wave of the one child policy in China and the huge abortion issue in India, and they're now seeing this huge in an area that traditionally had very little breast cancer. Now it's becoming quote unquote epidemic for them.
Mm-hmm. Well, what is the answer to refuting the assertion by the pro-abortion industry that abortion is safer than childbirth?
Well, the idea is to write papers like I do, is to present at meetings as I do, is to make them engage the literature and stop misleading people. Say, look, if you believe this, then you need to look at the other side of it. I'm willing to look at your data, but your data is basically of no use because it doesn't really come from reliable sources, and you know that. So why do you keep using the same unreliable data unless you really just don't want to talk about the real issue here? And to think that, you have a surgical procedure done on 1.2 to 1.3 million women a year and believe that it has no effect whatsoever seems to me the height of silliness. I mean, we all know there's complications to every procedure and everything we do in medicine. So to sit here and to, continue to tell the same myth is absurd. So, and what's interesting about it, now that we've brought all this forward, that's why these articles are coming out. You did not see these articles before we, on the other side, started writing about these issues like preterm birth, breast cancer, maternal mortality, psychological effects. Now suddenly they're trying to write articles and say all this, trying to refute. Well, the data is not on their side. The truth and the data are on our side.
Dr. Calhoun, could you just tell us finally about the Chang study regarding maternal mortality and abortion and the Carroll study in 2011?
Sure. Well, the Carroll study was done when we compared actually looking at the United Kingdom, Scotland, and Wales, essentially England and Scotland and Wales, and did basically a natural experiment looking at those countries with a very liberal abortion policy and their mortality rates compared to the Irish Republic and Northern Ireland, which had virtually restricted abortion whatsoever. And what we found is that the mortality rates in Ireland were about, as best we could calculate, were about about 1 to 2 per 100,000, and the mortality rates in England and Scotland and Wales were about 8 to 10 per 100,000, which is almost exactly the rate that Grimes and Raymond quoted for the United States, and that was the real mortality rate in places that had liberal abortion compared to those who did not have. The other study, the Chang study in 2003 that you mentioned, basically talked about that abortion-related deaths abortion had a hemorrhage and infection rate, death rates that were 8 to 9 times higher. So in other words, 8 times as many women died from hemorrhage from abortion and 9 times with infection compared to maternal deaths during the same time. So when you have a hemorrhage or an infection from an abortion, you're much more likely to die than you are if you've delivered a pregnancy.
I see.
So again, the data is just simply not in favor of the assertion that abortion is safer than childbirth. That's just not true. I mean, that's just not supportable by the facts.
Well, Dr. Calhoun, we really appreciate your time, taking time out of
Sure.
your day to be on the show, and
My pleasure.
we thank you for informing the public about this issue, and
Sure.
we hope to get it out there more frequently. And thank you for all the hard work and studies you've done.
My pleasure. Thanks for having me on.
Take care now. Bye-bye. And we hope you enjoyed today's show and found it to be unique, informative, content-rich, truthful, and thought-provoking. Thanks for watching. I'm Brendan O'Connell, your friend for life.